All right, guys, as I said before, I am so sorry that we had to cancel class tonight. I don't really like recording myself. It's kind of boring. I really like to have input and I like to talk about things outside of just speaking to a camera. So hopefully this information will be quick and hopefully this won't take up too much of your time. However, I would suggest that you guys review the information. As I said before, there's going to be a quiz coming up. I'll be sure to post it, make sure there's an announcement, everybody's aware of it. But just pay attention to the rest of the slides. If you have questions or comments, anything, you can either shoot me a message or you can just send me an email, all right? So we stopped off at falls. That's where we're going to kick back up. So any fall greater than 20 feet is going to be considered as a significant fall. I like to think about it as three times the person's height. So if you have someone who is essentially 6 foot tall, think about 18 feet. If they are, say, 5 foot tall, 15 feet is going to be significant. So likewise with kids, if anything's over approximately 10 to 12 feet for a child, that's going to be a significant fall for them too, okay? And there's all kinds of different things that can happen with these falls. So we're going to have to do a really good job of doing a head-to-toe exam, as we talked about, that we look them over. And spinal is something that we're going to have to consider. Now, what's odd is when a person lands on their feet, hopefully there's enough shock absorbing happening to the point where it actually takes a lot of the load off. However, there is a thing called axial loading, which is it distributes all the way through the spine. So consider that there could be some spinal issues to take care of. What I will urge you guys to do is be sure to take off their shoes. We have to check for that pulse motor sensitivity anyways, especially when we're fully immobilizing. So pop off them shoes and check to make sure that essentially the heel hasn't blown out through the skin. That can happen, has happened before in the past with people who has fallen directly to their feet. Okay, just something to throw in there to check over when you're in the field. So some things that we need to keep in count is also the height of the fall. As I said, anything over 20 feet is going to be significant. I would just tell you 3 times the height. What kind of surface did they struck? Now, listen, you know that concrete is going to be much harder than, say, just grass and ground. So that is very pertinent information to pass along to the hospital when we're calling our reports, whenever we're examining our patient for the high index of suspicion. All right. So which body part hit first? That's going to be another question. If it was their head, holy heck, there's all kinds of different things that could happen there, okay? So if they fell on their side, and of course remember that the presentation that they're going to give us, they might be laying on their back when we get there, but that may not be the exact location in which they fell. So it's an important question that we need to ask, okay? So jumping into penetrating traumas. Don't touch it, okay? That's the biggest thing I can tell you with penetrating traumas. You see a knife is into the chest of this person right here. What we do is we stabilize it. So what we would be essentially doing is taking these what we call clings, which is rolled gauze, and stacking it on either side of the knife and then taping it down, keeping it from moving. Because we know that when we move stuff, one, it makes more pain. Secondary to that is it inflicts more issues on the patient. So if we took out something like this, we do not know what that knife is exactly doing. It could be right up against a vessel right now, keeping that person from bleeding out. So if we pull that thing out, essentially we cause them possibly instant death, okay? So we just need to stabilize the object and transport the patient so they can get some x-rays, potentially CTs, depending on what the item is, and then the surgeons can come in and remove it properly without potentially killing somebody, okay? Typically, it's like I said here, it's the second leading cause of death in any type of penetrating trauma after blunt trauma, all right? So typically what we see is low injury penetrations whenever you consider knives and stuff, right? So the force that's going to be given is typically what a person can present. So we talk about the high velocity stuff that we're going to talk about in a minute, but with knives and spears and just even sticks, whatever, it's usually going to be a very low energy penetration. However, that does not mean that it can't completely go through the body. That's always a possibility. But most of the time, what's going to happen is it's going to get lodged into one particular area and it's going to stay. So we have to transport our patients with this. This might means that we have to get crafty with it. Unfortunately, rebarb accidents, which rebarb is part of building a structure, it's a steel piece of cord that helps to strengthen the concrete. People can impale themselves on those rebarb. So we can't necessarily take a 6-foot long piece of rebarb with us into the hospital, essentially because it won't fit in the back of the ambulance. So what we may have to do is get first responders personnel to get on scene to remove and start cutting pieces out of the way. Is that going to be uncomfortable with the patient? Absolutely. It's going to be terrible. So we have to stabilize that as best as we can while they're sawing through that. Sounds terrible. So ALS may be a good resource for that, just for the sole reason of administering some pain medication to keep the person comfortable while they're doing it. So also think about knives. Okay, so is the pattern that they stabbed in, now there's all kinds of different ways you can hold a knife, right? You can jab, you can kind of do an overhand. So the force is different here than what it is here, right? The other thing to think about is the person moving that knife while they're doing it. So you got to think about all the different organs that could essentially have been nicked and hit while the person was doing that, okay? That can be really, really, really bad, possibly, okay? So when we talk about projectiles, that's a whole different creature in itself. You can get shot with a bullet, especially with a lower caliber bullet, and it can ricochet and bounce all over the body. Two things you need to look for whenever we're looking for penetrating trauma: is there an entrance? Is there an exit? Especially when we're talking about bullet holes. I have seen people get shot in the hand and it come out their leg. All right, so do we know the trajectory? Not necessarily. That thing could have went all the way up and down their arm, all the way down through here, bounced off the rib cage, and get caught up in their leg. It's crazy, because guess what it does? It just bounces off all of those bones before it makes its final location. And we don't really know what that trajectory looks like, but we need to look for both of those things. And know that there are bullets out there, guys, that will fragment whenever they hit. When they do that, those pieces can go all kinds of different directions. So you might have an entrance wound, exit wound. However, you may not know about all the fragments that are lying inside of the person that didn't get dispersed out through their body. So like I said, a higher velocity bullet is typically going to go, it's going to cavitate, and we'll talk about that in a minute. It's going to go right straight through the body. However, if it's a lower caliber, it might go and either get stuck or it might bounce around and go to other places. Okay, that's always a possibility. So cavitation is those rapid changes of the tissue and the fluid pressure where it transitions and moves over. So look at that graph right there. As you can see, the permanent cavitation is that pink area where that is a hole that's being made. It's done. There's a hole there. And there's going to be this temporary cavity. That's going to be the percussion and the wave that's created from that essential cavitation where everything expands out. Now think about all the fluids and stuff that gets shifted, all the organs that get shifted during that time. It can be a whole mess, guys. It really can. So the relationship between distance and severity of the injury varies on the type of weapon involved. As I said, there are some that are, they have very low drag, so that means they go a lot faster. They're not bothered by the drag, so they'll go through, and they just like a higher velocity, it's going much faster. So just for a little while, there's going to be limited drag, and it's going to make a big hole in that person. The diameter, of course, of the projectile is going to make a difference too, right? And there are some, as I said before, that will actually expand upon impact. So essentially you'll have a small hole, but on the backside, you'll have a bigger hole. It's crazy, absolutely crazy. All right, and then we look at this chart. I'm not going to really hit this really hard because this is in your book, so you can take the time to kind of review this and kind of look it over really good. So it's table 24.1. So this kind of goes in and talks about the different penetrating traumas, and it's going to show you kind of how significant the signs and symptoms are and what index of suspicion you should have with each. Okay, so there's some medical terminology that's kind of being thrown in there. We kind of talked about pneumothoraxes and stuff, so you guys should have a good sense of what that is, but just take your time to kind of review this, and that way you have a good basis in which to step out on whenever you go to these calls. You're like, oh, okay, I understand this, I get it. So blast injuries. So unfortunately, the most common that we see, of course, is military conflict, and we know that there's improvised explosion device, the IEDs, if you will, that are used overseas. There was a lot of those were happening in Afghanistan, and those devices were being used quite a bit, and they were mangling people, and there was these secondary injuries were happening because of them. But other than that, what we see is the mines, the shipyards, the chemical plants, the terrorist attacks. Okay. So look at this graph. This graph is really good for information. So as you see here, there's the primary blast injury, which is the center. So that itself is exactly where it starts. Okay, that's your primary blast. So outside of that is the secondary blast, the tertiary, and the quaternary. Okay, and we'll kind of discuss what each will cause. Okay, so primary is typically the body's going to have this pressure wave that's going to push them. So think about the essentially a burn that could happen from it. Okay, so the fireball happens. That's going to be a primary. The secondary blast is going to be the flying debris that comes from that. That's why these pressure cookers and stuff are so dangerous, because you have essentially the percussion from the first blast. The secondary blast is going to be all the stuff that they may have packed in there, terrible as that may sound, going to strike them. The tertiary blast is if a person gets knocked back and then they hit another force. Okay, they fall back into a wall, and say that's their third. Quaternary blast is the gases. Well, I said burns is the first. I think that really should fall in there, but that's what the slides say. Respiratory inhalation, so maybe they come to and they start breathing all of this, all the maybe gases that were in there, so that's a quaternary one. There is some information, if you guys look in this one section, go to blast injuries. It'll help explain a lot of this stuff a little bit better. Okay, so I'm not gonna dwell on this for too long, but just go and look for that. Okay, and highlight that and look at that resource. So something else, hollow organs. I'm not gonna go through it, but think about all your hollow organs, guys. We talked about your solids and we talked about the hollow, right? So think about your lungs, especially the middle of your ear, the GI tract, basically anywhere in the GI tract, your gallbladder, all those items right there are hollow organs, in which there could be, they're susceptible to those pressure changes. So that quick snap where everything kind of expands or contracts, you're going to have a lot of issues with these organs. Okay, and most especially is the ear, because that is very sensitive to pressure. Therefore, hearing loss could be temporary, it could be a long-term, depending on severity. So pulmonary, we know pulmonary is lungs, right? Pulmonary blasts result in a short range of exposure detonation explosives. So arterial air embolisms. Okay, so that is arterial meaning the arteries, right? And air embolism is the kind of a blockage or a large bolus of something. So embolism, these can cause vision disturbances, also a change in behavior and state of consciousness, and a variety of other neurologic signs. So think about your carotid arteries, right? Come through here. So your carotid arteries can get fed with that air, and of course lock up any cerebral brain flow, and of course that's going to cause you to have those changes. Okay, so consider that as always a possibility. And think, not only do the hollow organs have issues, the solid ones do too. Okay, so the solid ones it can be very bad. If those are contused, then there's all kinds of bleeding that could essentially happen. Your liver is a highly vascular organ. A lot of blood flow, a lot of pressure goes through there, especially the kidneys too. The kidneys have a lot of pressure going through them. So if those become damaged, that could be very, very bad. And think about being, like it says here, hurled. Okay, so you get thrown away from it. You could land on your back, you could land on your stomach. There's no telling the different directions you could go. So that's always a possibility too. And as I said before, amputations are always a possibility. I hate to bring it up, and I hate to think about those issues that have been recent history, but the Boston Marathon bombing was one of those situations that could have been the people that did pass away could have been prevented solely by direct pressure and also by applying a tourniquet. If those two things had happened with their amputation, they would not have bled out and died. So that's why it's a big, big deal, guys. And we talked about multi-systems trauma. When we talk about blast injuries, all kinds of stuff is affected. So think about your neck, your head, any of the spinal canal. All kinds of stuff, your chest, your abdominal trauma. These are good patients to get to the hospital quick, okay? Hopefully we won't see any of this. However, we do live in the world now where terrorism is constantly being talked about. So we can't have our guard down with this, and we have to know how to treat these patients, okay? So some of the golden rules when we talk about these principles is foremost, of course, as always, your safety. Your safety is paramount. It's the most important part. Then safety for your crew, and then secondary to that is for your patient, and then bystanders beyond that. We may need additional resources with this, right? As I discussed before, there's a lot of things that fire departments and stuff, the tools that they have at their disposal that we don't have, that we need them to come in and do some cutting or some hacking or some moving or even just lift assistance to be able to get these patients out. They have the turnout gear. A lot of times we don't. Sometimes we do, depending on what agency you're with. So we need to make sure that we have that additional personnel. If you look at your step-by-step National Registry checkoff sheet, you'll notice that additional resources is high up. So that's once you get on scene, you should be able to look at the scene and be like, wow, there are 4 patients laying out here from an explosion. We're going to need more ambulances, more manpower. We need to get some more people in here. So that's where the additional resources lay. Evaluate the MOI. So we don't know necessarily if there's just that one bomb there, right? I know I'm talking about bombs solely, but with anything, but bombs especially, we need to be very cautious. There can be secondary bombs laid out here and there, so we have to be safe with that. But when it comes to the MOI, we discussed how a lateral impact from a motor vehicle collision could be a significant factor in deaths. So we need to look at that. And we also looked at the other principles, like another person has died in it, a person versus or a vehicle versus pedestrian or a bicycle. High index of suspicion because the MOI is very significant. ABCs, right? Address those life threats. Get them done, get them taken care of. If the patient is obviously bleeding, we need to stop that bleed, right? We got to take care of it. So get to it. Some other things we can do for shock therapy. So 1, oxygen administration. We talked about that, right? 2, keep them warm. Holy heck. Thermoregulation, guys. Okay, so when a person is in shock, they're not thermoregulating properly. Guess what kills a person faster? Being hot or being cold? Being cold. Your body does not clot well whenever it's cold. So we have to keep the patient warm. If that means that we're in the back of the ambulance and we have to turn that heater up to 100 degrees just to keep that patient warm, by golly, do it. We need to cover them up, at least without potentially covering up whatever injuries they have, but cover them up to keep them warm. Hot packs, we can put them on the major arteries, including under the axillary and also in the groin, okay, to keep them as warm as possible, and of course, expediting the transport as quick as possible. So there's also going to be surgical interventions that we're going to look for. Of course, we know definitive care is going to be big. So the golden 10, or the platinum 10, excuse me, the platinum 10 is we need to try to be on scene less than 10 minutes. Now, is that always practical? Absolutely not. There's always a possibility that extrication may take a long period of time. Other things that may be out of our control, we may be on there for a long period of time. However, once we get that patient with us, we shouldn't be on scene for any amount of time. We need to get them to the hospital quick. We're going to talk about other ideas in which we can transport. We'll discuss that a little bit later. But if you can, if it is at all possible, we need to try to get a sample history, okay? The signs and symptoms, allergies, medications, past pertinent information, last oral intake, events leading up to. This will cover us on the basis of, one, if we need to administer any medications, and two, could there be an underlying medical problem that could have caused this traumatic injury? Like I said, the diabetic emergency that caused a motor vehicle collision. That's always a possibility, guys. That happens. Or did they have a cardiac arrest, and that's why they hit two other people going down the road, and they are now deceased? Those are always possibilities, guys, always. So, yeah, so there it is. ALS, okay, always consider ALS with these situations, but also air medical transport. So one thing that they have that a lot of ambulances do not is they have packed red blood cells. So they actually carry units of blood with them. If you call them, you gotta let them know this person has lost a significant amount of blood, so we need you to bring some blood with them. And typically, most of the time they have it on there, but it's good to relay and let them know. They'll bring that blood with them and have it on hand so they can go ahead and start transfusing blood, because red blood cells don't do very good outside the body. And we'll talk about that with our next slide, or our next presentation. So as we go through this, guys, we need to look at the patient assessment. So this, once again, systematic approach where we're going, and we are seeing safety BSI, we're assessing life threats, we're taking care of those, we're doing C-collars, and we're doing the ABCs. And once we have made our transport decision, then we can kind of do more assessment. Now, whenever we essentially get on scene with these patients, it's going to be a quick down and dirty look. Okay, we're going to basically go from head to toe, and we're going to look at them rapidly. We should be able to put our hands on these patients, and we should be able to do a rapid assessment within 2 minutes, even less than that, maybe even less than 1. We should be able to go and put our hands on them and start pressing and start pushing on different areas of the body, looking in all the orifices, and also shining a pin light across their eyes, and then start pressing on the shoulders, arms, looking for pulses, motor sensitivity, and then we go down to the rest of the body, pushing on the pelvis, in and down, and then we work down the legs and check the pulse, motor sensitivity, and function, okay? So all that can be done extremely quick. And then once we do the front side, we need to check the neck, we need to check the back, okay? But we'll talk about that. I'm trying not to confuse you guys, but look at your skill sheets and look at the systematic approach for it, okay? And we know that head injuries are difficult. We may not be able to see anything. Okay, the only thing that we might get a clue about is, for one, they lost consciousness. Secondary to that, they may have this retrograde amnesia, which is typical of a concussion, but it can be indicative of other things. So retrograde amnesia is like they keep repeating the same questions over and over, or the same verbiage, or whatever. It's just over and over and over. It's because their mind's trying to reset and readjust, and trying to get that that circuitry, if you will, back in place. So a concussed person can sleep, just to let you guys know. There's a study that came out a few years ago that actually debunked the whole "don't let them sleep, it's bad for them." They found out actually quite the opposite, that that when a person is sleeping, essentially the brain repairs itself better. So if they sleep, that's okay. Just be sure to check a couple of things: SpO2 and blood pressure. And if you have a a cardiac monitor, at least you see some type of a blip, okay, on there. You don't have to interpret the lead, but if you can see something that looks kind of regular all the time, you're doing okay. Just remember that you can have this, what they call intracranial pressure within the head, that can cause all kinds of weird stuff can happen. So you can have I believe it's Cushing's. I'll have to look it up, guys. I don't want to tell you wrong. But anyways, normally what our body does is when it's in shock, the blood pressure will try to compensate. It'll go up just a little bit, and so will the heart rate. But with Cushing's, it's the other way around. So the blood pressure, the heart rate decreases and blood pressure increases. So you have this weird thing, and then you have an altered mental status on top of that. So that's a bad situation that tells us that the intracranial pressure is increasing. And you'll also start seeing this wide mean arterial pressure gap. So that's the difference between diastolic and systolic. If that starts widening, there's a lot of issues going on. The heart is not functioning like it's supposed to. So big deals, okay? So as I said, systematic approach, head to toe exam. So we start at the head, we're palpating, we're looking for the crepitus, the DCAP BTLS. We'll talk about that later. You guys need to know that acronym, okay? Learn that acronym. So deformities, contusions, abrasions, punctures, burns, tenderness, laceration, swelling. It's in your book and it's in the next slide. I'm trying not to go too fast. You can rewind back if you need to, if this is missed. Remember that swelling may prevent blood flow to the brain. That's a possibility. So if you have swelling here, say this trachea is swollen or there's contusion there on the muscle, that could potentially include all of this right here. So a lack of cerebral blood flow, that can definitely happen, okay? So also consider that penetrating trauma to the neck could potentially cause an air embolism. That is always a possibility. The only time that we need to take out any object out of anybody if it is blocking the airway here. If it's in the neck, we still leave it. Don't pull that thing out. Remember, there is jugular veins and arteries, carotid arteries all up and through there. Okay, there's internal, external, all kinds. So leave that thing in there. But if it is blocking their airway, we need to move it out. So something essentially that's poked through their face. Now, if they're able to tolerate it, leave it be. But if it is causing them respiratory difficulty and it could essentially kill them, that's the only time that we pull that out. Okay, guys. Then you have your crushing injury that causes issues to the larynx in the upper airway. Okay, so essentially somebody gets hit in the throat right here, that could crush them, okay? And they are not long for this world if that happens, because they're going to become hypoxic and going to go in cardiac arrest. So we may consider utilizing our ALS, and if they do lose a pulse, we know what to do from there, right? Just do our CPR. And advanced airway measures such as a King Airway or an iGel are excellent in those situations. Just remember, guys, that when we talk about the chest, there's all kinds of vessels and all kinds of stuff that could go wrong there, okay? Remember, like I said, the medium sternum, right here, the heart box is what they call it. All the great vessels go within there, of course, the heart and all of its chambers. And then you have the lungs just on the lateral aspect of that. All of that can be affected. And know that broken ribs can hinder breathing, so people are not wanting to take deep breaths because that furthers the pain. So they're going to have these short, shallow breaths because they don't want to hurt. Once again, ALS is a good idea for these situations. Know that there is a possibility that large vessels can be torn. Okay, that is a possibility. If you remember from your A&P, there are different layers of a vessel. Parts of the layers can get torn on the inside, or vice versa, the outside, and can still be intact. That's why we have to be careful to move these patients, because if that completely severs, they're going to bleed out and they are going to go into cardiac arrest because all the blood's going to come right out of them. It's like a water hose, if you will, that's been ran over or flexed too much. If you know how it swells out, you barely touch that thing, it could essentially explode. Kind of the same situation. So yeah, so if there is anything in the chest, we need to take care of it as quick as possible. If there is what they call, if there's a penetrating trauma, we'll talk about this in detail. It's easier to show in the classroom than it is to try to tell you here. But a penetrating trauma, say they have a hole through and through their lungs. The lung will essentially deflate inside the pleural cavity, and what we need to do is you have all this air that's coming in and that lung cannot expand. So what we need to do is cover that hole there. So first of all, we use a gloved hand and now cover that hole, and hopefully what that'll do is it'll allow that lung to reinflate and start getting bigger and bigger. That way we can have that perfusion. What we have to do, though, is we have to combat that. So what we make is this thing called a flutter valve. This flutter valve is a piece of occlusive dressing, so it's about yay big, that you just take off and you apply, and you make you tape it on 3 sides. And what it does is, as the person is breathing in, no air is coming into the hole, but as they breathe out, air is pushing out. Because the lung has to inflate, and once it seals off and gets reinflated, there should be hardly any air coming out of that flutter valve. And we'll talk about that, how to utilize occlusive dressing. Look it up if you guys don't mind, just so you get a heads up, how to apply occlusive dressing to penetrating or sucking chest wounds. Look it up and check it out. It's really cool to watch. There's other devices out there that do it for you, but just check it out, okay? And we know that the abdomen has a lot of stuff, right? So many things. Know that your solid organs are highly vascular. As I said before, your liver, your spleen. Spleen is a high mortality rate because there's a lot of blood flow. Kidneys too, because they are under a lot of pressure with the arteries they're attached to. All those things could potentially kill a person pretty quick if they're contused or lacerated. It's bad, really bad. And hollow organs, what we worry about that is mostly those gastric juices. So if your stomach leaks out, there can be all kinds of infection that can set up within the abdominal cavity. And of course, that may not kill them really fast, but very quickly after if it's not addressed and handled at a timely manner. Okay, and your bladder too. Don't forget about that. You know, that's also urinary contents, and that can be acidic. So we need to take care of that one too. Yeah, there we go. I kind of jumped ahead. I'm sorry. I do that sometimes. I apologize. Get on a little track. Okay, so a couple of things that we have to think about, guys. So our scene time is so important. We have to expedite these patients as quick as possible. So getting them loaded up and getting them to the hospital. If we can limit our scene time to under that platinum 10, awesome, man, that's where it's at. If the patient, if they're working on extrication as you're going to the scene, and as soon as you get there, the person's extricated, you put them on a stretcher and you go, and your scene time's like 3 minutes, what? That is the best thing you could ever do, guys. That's fantastic. Know that there are what they call critical patients. So those with a decreased LOC, so the level of consciousness, significant MOI, which we've kind of talked about that before, and any threats to the ABCs. So if they have a knife stuck to the chest, what is that going to hinder? Airway breathing, right? If they have bled out excessively, so they have an amputation, got to get them to the hospital. They're a critical patient, okay? Especially for the other aspect of surgically reimplanting that extremity that's been severed. So where do we take these? I'm sorry, I jumped ahead. So the transport. So you have options, guys. You can transport by ground, of course. We know that. We know that we can utilize ALS. That's always a possibility too. And you can also have a mix between EMTs and paramedics both. Then Buncombe County utilizes advanced EMTs and paramedics. That's the way they're set up. Also considered, as I said before, air transport. Those Helicopters, they can go as the crow flies as long as the weather's well, and they can get directly to the scene in a fraction of the time as most of us, especially when I talk about Madison County. One time the helicopter auto launched and almost beat us to the scene. And we had a 20-minute gain on them. So if that tells you anything, they can get there quick as long as everything is spot on. You know, if they have no troubles with their checkoffs before they launch, then they can beat us there. And know that these are staffed by critical care nurses and critical care paramedics and flight nurses, flight medics. So they can do a lot more stuff than essentially even I can do on the ground. As I said, transfuse blood. It's permissible in our state, but we are not signed off to do it. But just because blood is something that is, one, expensive, and two, you have to keep it refrigerated. So unfortunately, that's not going to be, you know, permissible in our county. Yeah. So the Medevac, AAMS, they have some criterias. So there's a criterias right there. So your multi-trauma patients, the mass casualty, the MCIs. If you have extended period of extrication, or maybe they're far out there, like a lot of our patients in Madison County, this is the time to call the helicopter. Call the helicopter to medevac all these patients. Okay. So let's talk about destinations. So level 1 facilities. You see it right there. A lot of times these are university-based hospitals. So Johnson City is the closest level 1 to where we're at now. It is right beside East Tennessee State University, so they are essentially like a university-based kind of hospital. Currently, Mission Hospital is a level 2. They are currently working on trying to get a level 1. So probably within the next year, they should be increased to a level 1. So there's not really much difference between level 2 and level 1 outside of being a teaching facility. They basically can render the same form of care. It's just one adapts more of a teaching philosophy. Excuse me. Then you have your level 3. Now these are the places that you go to stabilize a patient. So think about Park Ridge or Pardee out towards Henderson County. Also Haywood County is going to be another one that's going to be they're a level 3. So a lot of times what they'll do is they'll stabilize the patient and have them expedited and transported to the hospital. When I worked in Haywood County, I had to do this a couple of times. This guy was developing a pneumothorax, and I decompressed him, which means that I took a needle and I applied it to his chest, inflated a lung, but it started failing. So I had to stop at Haywood Regional Hospital. They had to put a chest tube in him to actually reinflate that lung, and then we're able to then transport him to Mission Hospital. So they stabilize the patient, we transfer him out, and take him to a higher level of care. And then your level 4 facilities, they can't do a ton of stuff. They call them Band-Aid stations. I know it's kind of a poor play on words, but that's what they call them. And these people, more or less, all they really do is they package them the best way they can, and then they ship them onto a higher level of facility. And then you also can break it down even further. So pediatric trauma and adult trauma. We do not have either. Johnson City does have a pediatric hospital and a pediatric ER. Mission Hospital just recently adapted a pediatric ER, which is still within the ER. It's not a separate building. It's a separate program, but not in a separate building. It's still in the ER section. So that's at least there. So they focus more on pediatric care, which is great. It's something that we definitely need. That way they don't get shuffled up and lumped into all the other doctors and physicians who may not be necessarily their forte. So this is another graph. You can pause it here and zoom in and look at it. It's kind of hard to see on this screen, at least for me. It might be a little easier for you. But you can kind of look at this and go through the steps and try to figure out your destination. It's easy here in the mountains because we only have one real major hospital. However, if you go work in a more urban environment where there's multiple hospitals, then you might have to utilize a pattern, and each agency is different. Yeah, there might be some that tell you to go to the IS hospital due to these injuries. So you have to remember all those things. But here it's easy. But I'll let you guys look at that at your own leisure and check it out and see just kind of read up on it. As always, we are the calm in the storm, guys. We always have to remain calm. If you act crazy, that's not going to help nobody. That's only going to make things even worse. So try to be as calm as possible. Even on the inside, you might be just a ball of nerves. Do your best to be calm, okay? As I said before, whenever we start working on these patients, a systematic approach is always going to be good. So be organized, be thorough, be methodical, okay? And we need to correct those life threats essentially whenever we get to them, okay? Bleeding out, take care of it. If they can't breathe, oxygen, all those therapies we need to take care of. We need to get those out of the way first, okay? Do no harm foremost, right? So if it potentially may put them in harm, if you are uncertain about the situation, talk to your partner or call medical control, all right? And never hesitate ever to call ALS backup. They will come and do what they can. Just know, as I said before, that if there's going to be a delay in transferring the patient from one ambulance to another, then you may want to consider to forego that, because time is tissue and time could be critical for these critical patients, okay? Medical control, as I said before, is always there for you guys. Boom. There we go. Done with this one. Good job, guys. Give you guys a second to think about this. So kinetic energy is a calculation of which of these two items. Give you guys 1 second to kind of think about it. Then I'm going to click over to the slide, see how you did. All right. So it is B. So it is the mass and velocity, guys, is what that is. Okay. So let's move on to the next one. So you have a 20-year-old male that has an open facial injuries. Not good. After a vehicle has struck a tree head on. Okay, wow. Okay, so we're going to stop that right there. So think about the significance of your MOI. Facial injury, head on, hit something, okay? Which of the following findings explains, which of the following findings within the car is most likely to explain this pattern? Is it the airbag, bent steering wheel, a non-intact windshield, or a crushed instrument panel? Remember, open facial fracture. What would be nice is if also it said restrained or not. It kind of makes a difference. But there's two in which I would lean towards. So if you got one and not the other, I get it. Okay. Okay. So more than likely it's going to be the windshield. All right. Now if it said forehead, essentially yes. So could a person strike the steering wheel, have the same injuries? Absolutely. That can definitely happen. All right, guys, I'm going to conclude it here. As I said before, hopefully next day or two, I'm going to have you guys posted a quiz online. I'll keep you informed about that. As I said before, once again, I reiterate it 1,000 times. Contact me if you have any questions or any comments about it. Okay, guys? All right. Have a good night. Look for the next one, the next slideshow for bleeding control. Okay, we'll talk about that. All right. Goodbye.